leading path for the pediatricians of the academy towards the betterment of infant and young child feeding practices in our country. And we have been able to make so many academic contributions through this chapter. I am very thankful to the past presidents for making this path of the chapter smooth at this juncture, and I look forward towards the incoming presidents and the teams that more and more development will happen with this chapter. And luckily, I think we are, this chapter is second or third in the strength among all the subchapters of IAP. And for last few consecutive years, the chapter had been bagging the best branch award also. So this is the dynamicity of all the members of this chapter. And for last few weeks, the IAP Thiruvananthapuram team has been very active hosting this conference, and we are thankful to Alive and Thrive for supporting this digital platform very generously and helping this conference in a big way. One more news that I would like to share is that IAP Kerala sub-chapter of the IVCF chapter is going to be launched within short time, and Dr. Elizabeth is very active behind it. It will be the second sub-chapter of the IAP IVCF chapter. So this is a great matter of pride that a lot of people are gathering together for this very crucial subject. And we all know that this subject is a very basic subject. It is not very glamorous also, so far as practices are concerned, but it is so important to the overall contribution to the nation also, not only to the child, not only to the mother, not only to the family. So these contributions of IVCF are recognized internationally worldwide, and now more and more awareness is gathering together, and we have got so many stalwarts in this chapter, so many seniors are there who had been working relentlessly and so dedicatedly behind the subject that now I foresee that their all work and efforts are growing and showing flowers and fruits, and the resultant outcomes, they are now coming up. So I earnestly request all the seniors, all the juniors and colleagues to contribute to this cause of infant and child feeding in all the ways, not only advocacy. We need a lot of advocacy, that is for sure, but a lot of research is also needed. So I look forward towards the so many teachers in this group, and I'm sure that they will take forward this subject through the postgraduate teaching in a long term, and that will make a sea change in the scenario of what is IYCF in coming decade. I will not take much time. I again thank Dr. Bakul Parekh for joining us on this evening, taking his valuable time. And I thank Dr. Elizabeth and the whole team, Priya, and I don't remember all the names, but please, as a team, you have done a great job, and I'm very thankful to all of you for joining here. Good evening.
Sir, now I request Dr. Professor K.E. Elizabeth, National President, Nutrition Chapter IAP 2017 and 18, and State President of IAP Kerala 2016, for her opening remarks.
Thank you very much. Good evening, one and all. This is the curtain raiser for 10th National IYCN Conference and 6th International Human Milk Banking Conference 2020. The theme of the conference is Nourish and Flourish. As the organizing chairperson, it's my pleasure and proud privilege to welcome each and every one of you, respected seniors, beloved friends, and well-wishers for the invocation ceremony. At the outset, I seek showers of blessings from God Almighty. We are privileged to have Dr. Bakul Parikh ji, Honorable National President of IAP, Dr. Kedan ji, esteemed National President of IYCF chapter, and Dr. Sadish Tiwari, National President of Human Milk Banking chapter, Dr. M. Narayanan, State President of IAP Kerala, faculty, chairpersons, and senior IAPians with us. I assure you a scientific feast amid all the hardships and restrictions imposed by COVID-19 on mankind. I also have a special request to you to become members of IYCF and HMB chapters. Thank you very much.
Thank you, madam. Now I request Dr. M. Narayanan, President State IAP Kerala, for his address.
Good evening to you all, respected dignitaries and dear colleagues. Warm greetings from IAP Kerala. And congratulations to the organizing team led by Dr. K. Elizabeth, Dr. Ketan Baradua, Dr. Sharmashekhar, and IAP Thiruvananthapuram team for organizing this academic extravaganza. A balanced diet should be considered as the basic right of every child. One of our presidential action plan for this year 2020 is right diet for every child. This conference is coinciding with the Child Rights Week celebrations of IAP Kerala. It may be a sheer coincidence, but it has got a lot of relevance also. I wish this webinar all success. Thank you. IAP.
Thank you, sir. Now I request our esteemed National President 2020, Dr. Bakul Parikh, sir, to kindly deliver the presidential address.
Yeah. So thank you, all the dignitaries on the screen and off the screen, and all the luminaries and teachers who are there present viewing this particular webinar. I am extremely happy to address this 10th National Iycncon and International Hmbcon 2020 organized by IAP Kerala and IAP Trivandrum. The theme, Nourish and Flourish, has been carefully chosen to create awareness and behavioral changes towards healthy eating. We always have to move from illness to wellness, and this is a very important concept where we have to pick it up. Maternal, infant, and young child nutrition is of prime importance for present as well as future health of all the infants and is directly associated with child survival. That's why the nutrition during first 1,000 days are always given lots of importance in this recent years. It is said to note that at least 1/3 of the children are stunted and wasted. Nearly half of them are anemic. And at the same time, 1/4 are overweight and obese. Optimum IYCF practices and healthy eating should become a lifestyle and lifestyle change, including adolescent and maternal nutrition. We should have nutrition counseling during all the immunization visits. And also there is a need for establishing human milk bank across the country. If you remember during Indore Pedicon, during my presidential election plan, I had declared that we should have at least one human milk bank in every district of the country. But somehow because of COVID-19, that activity has slowed down, but still, I'm not going to forget about it. And I'm going to go ahead with the support from Dr. Satish Tiwari and other of my friends to take it forward in the coming year. I have been working on this with various agencies and various companies who are ready to help us very positively. I am also likely to come up with a NAP program, that is Nutrition Addressing Program on our DIP platform, when we'll distribute that IPEN program to every pediatrician of our association, wherein you will be treating nutrition as an illness rather than just a casual counseling. Because unless until you take them as an illness, you are not going to address it very well in your busy OPD. So lots of importance has to be given to nutrition. And as you know that our President-elect Dr. Piyush Gupta is also chairman of the chapter PAN, that is Pediatric Association of Nutrition. So I'm sure it is going to be a big leap in this direction in the coming years. I'd like to congratulate the organizing team and the IYCF and HMB chapters for undertaking this national conference on digital platform. And I wish all the success for the conference. And I'm specifically thankful to Dr. Ketan Bhargava, the president, and Dr. Somasekhar, the secretary of IYCF chapter, and Dr. Satish Tiwari, secretary of HMB chapter, and of course the leader, Dr. Ken Elizabeth, and her organizing team for taking up this very important and pertinent topic as a national conference. All the best, and thank you very much for giving me this opportunity. Thank you.
Thank you, sir. We move on to the academic sessions now with three expert talks. Each talk will be for 15 minutes, followed by a 10-minute discussion. Kindly post your queries in the chat box so that they can be discussed at the end of the session. The first talk will be on complementary feeding, the bottleneck in IYCF by Dr. Priya Shrinimasan, Associate Professor of Pediatrics, Government Medical College, Trivandrum. To chair the session, I invite Dr. Sudhir Mishra, Chief Consultant and HOD Pediatrics, Tata Main Hospital, and HOD Pediatrics, Manipal Tata Medical College, Jamshedpur. May I request you to introduce the speaker, sir?
Thank you, ma'am. I hope I'm audible.
Yes.
Yes. It is my pleasure to introduce Dr. Priya Shrinimasan. She has already been introduced partly as the organizing secretary of this conference. And you can imagine that the efforts she must have made in organizing this conference are tremendous. It's not easy to organize a national conference otherwise also, and on a digital platform, it's that much more difficult. Dr. Priya Shrinimasan otherwise is an associate professor of pediatrics, and in addition to her MD and DCH pediatrics, she has done MPhil in clinical epidemiology, and that way she is a clinical epidemiologist as well. She has got a lot of papers. She has got best paper awards. She has written chapters in books. She has multiple papers in international and national PubMed indexed journals, and has co-authored chapter in the textbook of pediatrics, which was edited by Dr. Parth Sarthi. She has been a principal investigator of ICMR projects and Government of India projects. She has worked as secretary of IAP Thiruvananthapuram in various capacities, and she has been the secretary of nutrition chapter of IAP of Kerala. She is, of course, an IYCF trainer. I present to you Dr. Priya Shrinimasan, friends.
Thank you, sir, for that nice introduction. Good evening to one and all. As organizing secretary, I am very happy to welcome all the delegates to this prestigious national event. Let me move on to my topic. It is complementary feeding, the bottleneck in IYC. And in the next 15 minutes, we will see how much narrow is this bottleneck with the help of certain indicators and facts, and how to crack this bottleneck with the help of certain solutions at the individual level and also at the much larger level. And there are three indicators. The first one is the minimum dietary diversity. That is, a 6 to 23-month-old baby should receive at least food groups from at least 4 food groups on a daily basis. And the minimum meal frequency. That is, for a breastfed baby, 6 to 8-month-old should receive at least 2 complementary feeds per day, and a baby of 9 to 23 months should receive at least 3 complementary feeds per day. And if non-breastfed, the baby should receive at least 4 feeds per day, along with the 2 milk. And then you have the minimum acceptable diet. That is the combination of actually this minimum dietary diversity and the minimum meal frequency. And now let us look at the global scenario. That is from the State of the World's Children 2019. What does it say? Now, more than 70% of babies of age group 6 to 23 months are not achieving the minimum dietary diversity. And around 60% of babies are not being fed with animal source food by this age group. That is, animal source food is actually very rich in animal protein and the micronutrients. And around 40%, more than 40% of these babies of age group less than 2 years are not being fed with any kind of vitamins, that is vegetables and fruits. And what is the situation in India? That is 6 to 23 months. We have 2 sets of data. That is the NFHS 4 and the CNS 90. That is And these two data have been combined by the government of India, and another document has come in 2020 June. And what does it say? That is, the timely initiation of complementary feeding at 6 months is happening only to the tune of 45 to 50% in Indian babies. The minimum dietary diversity is achieved only in 20%. The minimum meal frequency is achieved only in, say, 36 to 40%. And the minimum acceptable diet for these babies, it is achieved only in a meager less than 10%. And how to crack this bottleneck? First of all, it is the timing. We know that complementary feeding should be executed at 6 months of age, and it should be initiated at 6 months of age. Now, there can be early initiation as well as late initiation. Now, there are certain scenarios like inadequate breast milk mothers may say, working mother, and sometimes out of ignorance. Now, here one-to-one discussion with the mother should be done. That is, we should tell them about the benefits of breast milk and the benefits of breastfeeding. And the developmental readiness also, we should talk to the mother. That is, the baby should be able to open his mouth, should be able to take inside the spoon. That is, there should not be any tongue thrusting reflex that should go. And the lateral movements of the tongue should come so that the baby should be able to keep the spoon inside, let the spoon inside the mouth. And there should be a lip seal, should be able to scoop off the food from the spoon when the spoon is, and should let go out the spoon. So all these things should happen, and then the baby should be able to swallow. So that is the developmental readiness which should happen. And when you introduce these complementary feeds yearly, there is no immune maturity, and so they are more prone for GI infection. And again, when they are introduced before 6 months of age, there is chance of obesity also. And another issue is late introduction after 6 months. Here, the scenarios is mainly because of some cultural reasons, ignorance, and again, the mothers may say baby wants only breastfeeding and is not interested in complementary. Now, here what we should say is that this breast milk alone will not suffice after 6 months of age. These babies are developmentally ready after 6 months of age. And we should tell them that the complementary, why they are not accepting complementary feeds is because the complementary feed is not prepared properly. And maybe the quality may not be good, the quantity, the consistency, all these things. And the concept of responsive feeding also we have to tell the mother. And regarding the quality, the scenarios are some of these mothers tell that these babies are not interested, not gaining weight, and sometimes they present to us with micronutrient deficiencies, and sometimes they may be having constipation. And we should know that the feed which is given should be more energy dense, that is 0.8 kilocalories per gram. And by 6 months of age, you can start the mono cereal, that is, you can start with either ragi or banana powder. And then after 3 weeks or 4 weeks, you can start the cereal pulse combo in the ratio 2:1. And then what the new IYCF guidelines tell is that you can introduce with vegetable purees that can be given. And you can make it more energy dense by adding oil, ghee, coconut oil can be added, coconut milk can be added, and the jaggery is said to be more micronutrient dense. And by 7 to 8 months, what we should know is that animal source food should be introduced to prevent iron deficiency. And it is rich in micronutrients. And by 6 months of age, these babies, their taste buds will be more programmed so that they'll have his own likes or dislikes after 8 months of age. And so the acceptance of food which is introduced later is found to be poor. So I have to introduce all kinds of foods before 8 months of age. And at least I have told before, at least 4 out of the 8 food groups. What are these 8 food groups? We know about these 5 food groups in the according to the My Plate concept. And then again, this protein is divided into three. That is egg protein. Then it can be plant proteins like the legumes and nuts. And then you have the animal proteins like the poultry and fish. That is how it is divided. And again, these vegetables and fruits have been again divided into vitamin A rich fruits and vegetables. So that is how it has come like 8 food groups. And the baby needs water and fiber containing food also. And regarding the consistency, now this is very important. That is, most of these mothers will tell that the baby is spitting out food, gagging, all these things. So we should, again, we should look into the developmental aspects. 0 to 6 months, it is just this suck and swallow, which is the horizontal like kind of movement. And then by 6 to 7 months, there is the up and down like kind of munching movements which occur. And by this age, you should start the semi-solid thick and feed. And that is the first picture which is shown. And then by 7 to 9 months, it is very crucial or critical because the baby starts biting and chewing. So you have to start the lumpy food. That is the second picture which is shown. And if lumpy food is not introduced at this age, it is very difficult for the baby to accept the later solid food. And by 9 to 11 months, biting and chewing starts. And it is very important to give textured or more coarser foods. That is the third picture. And finger foods should always be introduced before 10 months. That is the fourth picture. That is the like boiled vegetables, tomatoes, uh, carrots, then boiled potatoes, scrambled egg, chicken fibers. All these things can be given. And after 1 year of age, the baby develops this rotatory chewing movement. And so by that time, you can start the family food. And then regarding the quantity and the frequency, this is very important because if you give more food, that is more quantity and more frequent means there will be overfeeding, the baby will vomit out the foods, there is more chance of obesity as well. So that you should know the stomach capacity of the baby is 30 ml per kg. So you feed like 20 ml per kg because you should give room for the juices and for the, that is for the digestive juices and for the air. And by 6 to 8 months of age, the feed is like 2 to 3 feeds per day. That is for a breastfed baby. And from 9 months onwards, you can give at least three, that is 3 to 4 feeds, with along with snacks 1 to 2 per day. And that is easy to prepare. Snacks made at home. And the quantity is like for a 250 ml katori. In infancy, it is half katori, and after infancy, it is 3/4 katori. And for non-breastfed baby, again, the frequency is like 3, 4, and 4. And we should tell them about the concept of this responsive feeding because there are certain scenarios like mother may say fussy eaters and having food is like a wartime and media influence, obesity, and neophobia. So you have to tell the mother to recognize the cues of both the hunger as well as satiety and to respond appropriately. And it should always be a learning experience. There should be eye contact and it should actually be happy moment rather than forceful feeding and wartime. And it should actually happen in a media free zone distractions. The baby as well as the mother should concentrate only on the food. That is, the baby should know the variety of textures, the different combinations, the different colors, should know the taste of food, the smell of food. All these the baby should experience. And complementary feeding means continue breastfeeding till 2 years of age. And this becomes very important during an illness because during an illness, these babies they will accept breastfeeding well, but will not accept other kinds of feed. And it is soothing also to the baby. And we should tell the mother that this again, this breast milk, even at 2 years of age, the breastfeeding or the breast milk is able to satisfy the 30% of energy requirements of the baby. And it is said in the WHO module that at 18 months of age, it is able to, that is, it is able to, it has around 70% of vitamin A, 40% of calcium requirements, and around 40% of these riboflavin. All these requirements will be met by the breast milk. And one important practical point is regarding the working mother. And these babies may come to us with malnutrition. Again, obesity can also happen, caretaker issues, stressful events, and infections because these babies may be sent to some daycare centers. And here it comes at much higher level because Maternity Benefit Act and the maternity leave, it will finish off by 6 months. And from 6 months onwards, these mothers will be is forced to do good for work. And it is why we know that during this time that complementary feeding starts. So all these complicated issues will start after 6 months. So we should do something about it. And the workplace support is important. And joint family, for the sake, the joint family should be promoted, and we should empower fathers as well. And pre-cooked food, that is roasted and powdered cereals and powdered cereals and proteins can be encouraged. That is, you can prepare it early and can keep it in containers. A maize rich flour, that is again it can be prepared and can be added to the fresh food. And fruits and vegetables, we have to tell them about the concept that these are ready to eat foods rather than the junk foods. Easy to prepare foods like egg and milk products like paneer, which is rich in protein. And the family pot feeding should be introduced after 1 year of age so that by that time the mother need not cook separately for the baby. So that also you should tell. And these mothers, they may resort to bottle feeding. And so we have to tell them to avoid bottle and to ensure hygiene. And regarding these preterm babies, now we know there are issues. More babies are surviving. They are not gaining weight. There is inadequate breast milk. And sometimes they may not be tolerating the complementary feeds. And tube feeds may be prolonged tube feeds and maybe having lots of comorbidities. So in this scenario, actually clear-cut guidelines doesn't exist regarding when to start complementary feeding in preterm babies because it is actually individualized. But a systematic review has come in the Nutrients Journal in June 2020, which tells that it's it is individualized, but generally speaking, you can start complementary feeding by the age of, that is the chronological age of 5 to 8 months of age, provided these babies have reached at least 3 months of corrected age. So, for extreme preterms, that is less than 28 week babies, there you should look for the corrected age of 3 months and then start complementary feeding. And this is the last slide that is at a much higher level. And here some policy decisions, some government decisions, all these should come. That is anticipatory nutrition guidance should be started for these mothers well before 6 months of age, say by 5 months of age or so. This guidance should be given, like how to feed, what to feed, when to start complementary feeding. All these things should be taught to the mother. We have to empower these ASHA and Anganwadi workers because after all, they are the ones who are going to see these mothers and talk to these mothers on a one-to-one basis and tell them about this growth chart filling as well. And again, I have told about empowering working mothers. Then food fortification should happen in on a larger scale. And supplementation programs, we have a lot of these, they should be strengthened, like the anemia, Muft Bharat, vitamin A. Vitamin D should come up in a government programmatic manner, zinc and iodized salt. And again, strong implementation of the IMS Act. And junks, we know the media influence. So a control should also come over. That should be strengthened. And thank you. This was one of our sessions, that is complementary feeding sessions, which we conducted at a remote primary health center. That is IAP branch, IAP Trivandrum branch conducted it for Anganwadi workers and mothers. Thank you.
Thank you, Dr. Priya, for this wonderful talk on how to crack the bottleneck of the complementary feeding. This is one of the major problems that remain in the infant and child feeding, and that is where the children start suffering. She has very nicely told how much to give, what to give, and when to start, including for preterm babies with a corrected age of at least 3 months. Thank you, Dr. Priya. And I thank the organizers for giving me this opportunity to chair this session. Thank you very much.
Thank you, sir. Now we move on to the second talk, Malnutrition and NAIDS, which will be chaired by Dr. Lalita Kailas, Professor of Pediatrics and Principal, Sri Gokula Medical College, Trivandrum, and she'll introduce to us the speaker, Dr. Shrinimasan, Registrar, ICH and HC Chennai. Welcome, Madam.
Hello. Distinguished office bearers of the IYCF, as well as the distinguished faculty members of this esteemed conference, and all other senior colleagues and viewers. A very good morning to one and all. I consider this as a privilege for me to be a part of this conference, and I thank the organizers for the invite. And I'm extremely happy to introduce Dr. Srinivas. He is actually the State Child Health Nodal Officer under NHM for the state of Tamil Nadu. And also he's a registrar in ICH, Institute of Child Health, Chennai, with more than 31 years of the government service. And because he's both an academic as well as interested in the public health experience or public health work, he has been able to establish around 73 NICUs, SNCUs, that is Special Newborn Care Unit, throughout the Tamil Nadu, as well as he has been able to establish pediatric resuscitation and emergency medicine units in district hospitals and various NRCs, also nutrition rehabilitation centers throughout the state. And so with all this, he has been instrumental, or somehow he has contributed to the reduction in the neonatal mortality rate as well as the infant mortality rate of the state of Tamil Nadu. More than that, he is involved in so many research activities related to the nutrition as well. So I think he's the most apt person to discuss about the malnutrition and NAIDS, that is the nutritionally acquired immunodeficiency syndrome. We know actually very well, we are all aware that the malnutrition is associated with a significant impact on the immune system, whether it's a carbohydrate or a protein or whatever it is, and it affects both the cellular as well as the humoral immunity. Naturally, as in any other immunodeficiency, it leads to more and more of infections, and then it worsens the malnutrition. But this term of NIH is only recently coined, that is in 1992. But unlike the HIV NIH, this has got a better prognosis, so that we can treat the immune system with effective nutritional implementation, and much more than that, we can even prevent it, unlike the HIV AIDS. So to enlighten us on these different aspects of the nutritionally acquired immunodeficiency syndrome, we have the most apt person. So I'm inviting Dr. Srinivas to deliver his lecture. Over to you, sir.
Lalita Kailash madam for introducing me and saying nice thing about me. So, nutritionally acquired immunodeficiency syndrome. We all heard about NSAID. Here the S has been taken out. But as S. Srinivasan, I have come here to talk about this NSAID. So, I move it. Yeah. Yeah. So this is a kind I like to start in the beginning. The illiterate of the 21st
You can change to the full screen, sir.
Full screen. Put it in the full screen. The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So this NAID, lot of things has to be learn, unlearn, and relearn. So I'll start with this initially. Now this is the normal immunological system. Any person would like to see how B cells and T cells are coming out from bone marrow and thymus. And you can see the B cell, you can see pre-B cell, immature B cell, then mature B cell, then all the immunoglobulins are formed. This is all primary immunodeficiencies where at various levels, when there is a genetic defect or maybe due to the environmental defect, you may get problem in the form of combined immunodeficiency syndrome, agammaglobulinemia, IgA deficiency, T lymphocyte deficiency, variable immunoglobulin deficiency syndrome. This depends upon the various stages, the defect which occurs because of the genetic problem and the environmental problem. Today, what we are going to see, the same B cell and T cell is how it is going to be affected by the nutrition, and how that's why we say it is called secondary nutritionally acquired immunodeficiency syndrome. We are see many invariably the most of the macronutrients and micronutrients are going to be the most important constituents in dealing with this immunocompetency of the children. So what do you mean by immune response in children? When you say immune response, there should be a cellular proliferation and there should be a synthesis of protective proteins which is going to protect the children from many infective diseases. What do you mean by early immune response? When I say early immune response, especially from the newborn period, it should be mainly from the mother. It's maternal IgG which is transferred from the mother to the baby, and the IgA from the breast milk. Because children leads to IgG and IgM adult level will come to children only at 4 years. You can see in this picture, whenever a mother is getting infected or ingested some organisms, which is going to the lung and to the Peyer's patches in the intestine, from there with the specialized B lymphocytes, they get transferred to the lymphatic system through the blood supply. Then they go to the breast tissue where the IgA is being secreted. And so in nutshell, IgG is given from the mother, IgA is from the breast milk. So many studies have proven that early severe nutritional deficiency, that means a maternal malnutrition, when she is going to have an IUGR with severe malnutrition, then it's going to run for many transgenerational immunodeficiency. If you see this picture in a normal nutrition during pregnancy, where the normal epigenic status has been maintained with no mutation, and if you give a wonderful environment with good breastfeeding, good delivery, good mothers taking care, everything is fine, you get a normal, healthy adult. On the other side, when there is a severe malnutrition during pregnancy, what happens? There is an abnormal epigenetic status with a lot of mutations, and they don't adapt to the surroundings. That goes maladaptation that leads to transgenerational immunodeficiency. It may be in the form of non-communicable disease like obesity or diabetes. We can see many IUGR babies are prone to go for diabetes, maybe because of the Backus hypothesis. So what happens in preterm, especially in IUGR babies? See, normally, whenever you have a child with malnourishment, she is going to be the teen with malnourishment, and she's going to be the adult with malnourishment. You get a LBW or IUGR baby. So in preterm, when the baby is getting delivered even before the late third trimester. When I am saying the late third trimester, it may be from 35, 36, 37, 38 weeks of life of gestational age. When the baby is getting delivered before that, what happens? There is no maternal transfer of IgG occurs from the mother to the baby because of the premature deliveries. And you see the transfer of zinc and iron from the mothers also takes place in the third trimester. That means these preterm babies are going to be without IgG, are going to be without zinc and iron. That leads a lot of syndromes in them. In fact, these preterms can have an impaired vitamin A also. If you see this picture where a pregnant lady, when she has a lot of IgG, see the transfer of IgG from the pregnancy to the baby mainly depends upon the integrity of the placenta, quantity of the IgG with the mother, and how this is going to be transferred from the mothers to the child, whether it is during the term or before term, that is depends upon the gestation also. FCNA, this is situated in the syncytium of fibroblasts, which is the one which mediates the transfer of this IgG. And in fact, the placenta acts like a placental sieve, and they give a right immunoglobulin to the babies. And this immunoglobulin, then they can combine with the galactose, they form some proteins, and they can then enhance they can act on the NK cells degranulation. So that means the prematurity, the gestation age, how much IgG mother is having, and how the integrity of the placenta. All this plays an important role in the transfer of immunoglobulin from the mother to the baby. Of course, you get IgA from the breast milk, IgM and IgD may be from the vaccination. So early infant nutrition, that is very, very, very important. This is one of the one which determines the factors like the early immune response which the child is going to get, whether the child is going to have a risk of infections or not, and whether the child is going to have immunomediated syndromes. If you see this picture where the first 1,000 days, which is very important, where you can see a desirable impact and undesirable impact. You have an antenatal mother with a very good balanced diet, with good nutrition, with good microbiota. If they go for normal delivery and the baby is a term child and you start the breastfeeding, give the colostrum, right complementary feeding, that you are going to have a very nice child for the first 1,000 days. Let us see the macronutrient which is going to have the direct relation with the immunodeficiency of these people. Of course, we all know that breast milk is the most important one, which has a lot of anti-infective properties. You can have growth factors, long-chain fatty acid, lactoferrin, antioxidant, glycoprotein, IgA, cytokines, chemokines, so many things are there. So this breast milk is going to make the immature the immunological system in the baby to the tolerant immunological system. Of course, it mainly depends upon the maternal age, maternal parity, genetics, immune status, on everything. You can see each and every component has got its own act. IgA, it acts on mucosal barrier. Cytokine can have an immune microenvironment. That means breast milk has got a lot of advantage in giving immunoresponse to these babies. See this picture here. I already told you IgA comes from the breast milk, IgG from the maternal side, IgM may be due to the vaccine. Breast milk, the most important, two important things I want to talk. One is the immunoglobulin A. That is very important. It has got both passive immunity and both active immunity. When I say passive immunity, this immunoglobulin can neutralize the bacteria and the toxins, especially like Campylobacter, Vibria, and E. coli, which is targeted against the gastrointestinal tract. When I talk about active immunity, there are many people where they have found that there is a presence of anti-idiotypic antibodies which acts very well against the cytomegalovirus infections, especially in the breast milk. So what are the other things you have apart from this IgA? Lactoferrin, that is also very important. When I talk about lactoferrin, it has got a wonderful property which combined with the iron binding capacity, and it acts as an anti-inflammatory also. Because of the iron binding capacity, some of the gut flora which has got a pathogenic organism which are very fond of iron cannot have any problem in this child. So lactoferrin by this as acting like a immune bridge for all these children. Cytokines, you have an interleukin 1, interleukin 6, interleukin 8, macrophage activating factor, collagen stimulating factor. All these interleukins, cytokines, are helps in leukocyte protection, activation, and of course mobilization also. Then you have a carbohydrate, oligosaccharides, glycolipids, glycoprotein. They prevent the adherence of streptococcal pneumoniae, H. influenza, E. coli, and Vibrio cholerae. Of course, the lipids like lauric acid has got an antibacterial and antiviral property. Essential fatty acids stabilizes the membrane. Micronutrients and its immune response. It has been found that whenever there is a deficiency of a single micronutrient or a multiple micronutrient, it is unfortunate that before the deficiency of the micronutrient comes, the immunological deficiency comes in this child. That is a worrying factor. That means we cannot wait for the micronutrient deficiency to occur, because before you see the clinical signs of micronutrient deficiency, the immunological deficiency is going to occur in these children. So let me talk about iron. We know everybody talks about a lot of anemia in children, but this iron is very important in normalizing the T lymphocyte. It also normalizes the delayed hypersensitivity response. It has got, it will reduce, if the iron is not there, IL-2 production is going to be less. But of course, one study which has been done in Toga, where around 170 children have been studied with anemia from 6 months to 36 months. What they found that when these children are depleted with anemia, higher dose of anemia is not giving much of a immunological response. Of course, the correct dose of anemia corrects the anemia, but iron, we cannot say it may give complete immune protection, but the adequacy can be meted by giving the iron. What about zinc? Whenever the zinc deficiency is there, there will be impaired lymphocytic and phagocytic functions. It reduces the morbidity of ARI and ADD syndrome, acute diarrheal syndrome and respiratory tract syndrome. It reduces. So zinc is very important. In fact, during the COVID time, it is one of the wonderful drugs we are using for even children, zinc with vitamin C as an immunomodulator. One of the Nepalese study has found that out of 1,700 children who are suffering from diarrhea, giving zinc is very important, very essential. But of course, it's not modifying the mortality, but it reduces the morbidity, it reduces the duration of the ARI, it reduces the duration of the diarrhea also. Because everybody should think that when you go for high level of zinc, then there may be a improper absorption of copper may occur. That should be brought in our mind whenever you use high dose of zinc. Vitamin A deficiency cause induced T cell activity, natural killer cell activities reduce, decreased interferon. Again, there was not much evidence that vitamin A increases the immune activity in a replete children. The children with the deficiency, you give vitamin A, it fills the adequacy, but we cannot, many studies show no evidence shows that it will improve the immune activity. But vitamin A is very essential, and when you use vitamin A, please think about the toxicity of vitamin A whenever you prescribe to the children. Of course, those days in the 80s and 90s, many preterm babies are prescribed with vitamin E for the immune protection. Many studies were done in adult, not in children. Elderly people showed a lot of immunocompetency when they use vitamin E. In US, children consume vitamin E for nutritional adequacy. Then, of course, vitamin C. Yes, it is very helpful for common cold. Again, many meta-analysis showed that it can reduce the prodromal symptom. It reduces the duration of this one. B12, B6, B12, folate biotin deficiency. B12 is very important. Of course, we can remember a syndrome called Emerson-Hasselbalch syndrome, where the B12 deficiency comes with microcephaly, conversion, delayed motor milestones. Few syndromes we can see because of B12 deficiency, orotic aciduria, and other things. Of course, these are very important, but most of this micronutrient, unfortunately, not much of study is been there for the children to go for it. Nucleotides, yes, this is present in breast milk. It is fortified with milk powder. Some study shows there is an improvement in interleukin 2 killer cells, and it also acts as an anti-allergic for food antigens. But more studies is needed regarding these nucleotides. The long-chain polyunsaturated fatty acid, which contains DHA and arachidonic acid. Of course, both are very helpful for visual acuity and cognition. And it has been found that whether it has got real immunological response. It has been found that many children who comes with a lot of skin syndromes, with eczemas, when those mothers are tested, when observation study has shows that those mothers are showing very low DHA and very low ARA. That means it has got some relations with the skin-related disorders. And it has been found that when preterms are added with DHA and ARA, there is a remarkable increase in CD4 in giving excellent immunoprotection, a study done by Field et al. Then of course probiotics, yes, many people started using probiotic for diarrhea and atopy. Human impact in fact enhances the probiotic bacteria. Again, lot of study is needed. You get lot of variety of strains of bifidobacterium like lactis, longum, bifidum, breve. They all got immunity, GI support, anti-aging. So a lot of good things are there regarding the usage of probiotics in this. Whether we can use the health products, whether it is going to give immunoprotection, still many answers to be given because health products are not really labeled properly. More, if at all the drug enforcement can interfere with the health products only when they prescribe as drug. Unfortunately, it is not prescribed as drug. It is sold in many markets. They don't contain what they contain. Many side effects are there. So it's a big question whether health products can be used for immunoprotection. I will say no. Then, of course, what is the summary? Let me finish with the last slide, the summary. Adequate nutrition is must not only for children from the adolescent period, from the antenatal period, when before women during marriage, they should have an adolescent nutrition because I told you, malnutrition in a woman is taking care of many generations with the immunological syndromes. Human milk, I think, is by far the only proven best one for protecting any immunodeficiency syndrome. Of course, some children, micronutrient and macro to be taken care. Use of this is the question, whether use of high dose of nutrient supplements is going to help you in the form of high dose of vitamin A, high dose of zinc, high dose of iron. Whenever you use all these in high dose, we should be taking care of the side effects of high dose of vitamin A, zinc and iron. But adequacy will be definitely maintained. The long study, more studies are needed to see about these micronutrients giving an excellent immunological response. Of course, a stable a balanced diet which gives a stable micronutrient definitely protect many children from nutritionally acute immunodeficiency syndrome. So I thank the organizers for giving this opportunity. I hope I finished in time. You are what you eat. That's all. Thank you very much, madam. Thank you.
Thank you, sir. I request Lalita madam if there is any questions in the chat box that can be taken up now.
They have seen. Thank you, Srinivasan, for that excellent disposition of the topic.
Thank you, madam. Thank you, madam.
One question from Dr. Ramachandran. Is there any need for a requirement of iron and vitamin C requirement to be replaced routinely? Dr. Srinivasan?
Madam?
Is there any need for routine supplementation of the iron and vitamin C?
No, that's what, madam. That's what I say not necessary because whenever we go for higher dose of iron or vitamin C when it's not prescribed, the side effects takes over more. Than many studies have shown that not much of very big immunological response when you go for higher dose of vitamin C. But what is required when there is a deficiency, it should be treated. There is no need to supplement for a normal child just because to prevent micronutrient deficiency, madam.
Okay, I think we have only one question. If there are no other questions in the chat box, once again, I thank Dr. Srinivasan and thank the organizers.
Thank you, madam. Now we move on to the last talk of the series, the third one, which is on COVID-19 and nutritional immunity by Dr. Shrija Sugunan, Associate Professor of Pediatrics, Government Medical College, Trivandrum. We have Dr. Ashraf TP, Additional Professor, Department of Pediatrics, GMC Calicut, and State President, Adolescent Chapter, IAP Kerala, Member Board of Studies, Medicine, University of Calicut, to chair the session and introduce the speaker. Over to you, sir.
Thank you. First of all, let me thank the organizers for inviting me to chair this important session, COVID-19 and nutritional immunity, a topic of current importance. The whole world is on search how to prevent COVID-19 and its complications. Some of the vaccines are under phase 3 trials. Still, it is not a reality. There are a lot of discussions in the scientific arena as well as in the public about the nutritional agents which prevents COVID-19 or which prevents the severity of the COVID-19. Some of them are facts, but most of them are myths rather than facts. So today we will have Dr. Shrija Sugunan. She is the proactive and committed pediatric intensivist from SIT Hospital, Government Medical College, Trivandrum. And let us hear from her what are the scientific basis of nutritional immunity and COVID-19. Over to you, Dr. Sheeta.
Is the screen seen? Can you view the screen?
Screen കാണുന്നുണ്ട് ഷിത, പക്ഷേ your slides are not visible. Open the slides.
ഇപ്പൊ കാണോ സാറേ?
ഇല്ല.
somehow ടെലിഗ്രാമിന്റെ ആണ് കാണുന്നത്.
ടെലിഗ്രാം ഓപ്പൺ ചെയ്തായിട്ടാണ് കാണുന്നത്. ഷീജ, are you using a laptop?
Yeah, I'm using a laptop. I'll just see.
Please copy your PPT on the desktop.
Well, it's there on the desktop. Let me see. Just let me see.
Shija, it is better to stop sharing and രണ്ടാമതൊന്നുകൂടി ചെയ്തോ.
I stop sharing and close this one. Then again you open now.
Again share. That is better.
Stop share ചെയ്തിട്ട് ഒന്നുകൂടെ ചെയ്യാൻ.
ലാപ്ടോപ്പിലെ മറ്റ് ഫയലുകളൊക്കെ ക്ലോസ് ചെയ്തേക്ക്.
And close that file which was showing on the screen. Close that one and then again go to share screen and you share your PPT. I don't have your presentation, otherwise I could have shared with.
It's showing whiteboard only.
Please close all the files in your desktop.
Close all the files.
Keep that PPT also in a closed.
Dr. you need to open your PPT first, then start, then click share screen and then select the open PPT. Otherwise, it will show white screen only.
Okay. Thank you, sir. Yeah. I think now you can see, right?
Yes, yes.
Okay. Sorry for the interruption.
Not at all. Go for this slideshow. Okay.
Full screen.
Okay. Thank you, Ashraf, for this kind words. And thank you, Elizabeth Madam and the team for giving me this opportunity. So coming straight to the topic, that is immunonutrition and COVID-19. This is exactly the expression I had when I got this topic, because you have so much in the net and so much being said and written about nutrition, immunity, and COVID-19, especially because COVID-19 does not have a strict treatment. So what I really plan to cover in the next 15 minutes or so would be mainly concentrating on the three recent superstars, that is the vitamin C, vitamin D, and zinc. We all know that we have three layers of defense, that is your physical barriers, your adaptive immunity, as well as your innate immunity. And nutrition plays a very important role in maintaining all these three defense layers. And it's very important for us to understand that there's no magic bullet, there's no magic nutrient. Every nutrient is necessary for having a proper immunity. We all know that you need energy to fight the virus, you need amino acids or protein to produce the essential antibodies, and you need your multivitamins as well as your minerals to regulate the immune response. Having said that, don't forget about the fibers, because high fiber foods promote microbiome diversity in our large intestine. A healthy gut microbiota has been shown to play a key role in the body's immune response. So all said, each and every nutrient is important in one way or other. So we beautifully heard Srinivasan sir's talk on the nutritionally acquired immunodeficiency syndrome. We also need to know that just like undernutrition makes us more susceptible to infection, overnutrition also makes us more susceptible to infection. Obesity causes altered leukocyte counts as well as cell-mediated immune response. We need to know that obesity leads to increased production of leptin, which is pro-inflammatory, and reduction in adiponectin, which is anti-inflammatory. So obesity is a chronic pro-inflammatory state. And that is postulated as one of the reasons why children or adults or adolescents land up having metabolic disease. That is mainly because of the hypoxia occurring in the hypertrophied adipose tissue stimulates the expression of inflammatory genes. And we all know that there's a very high prevalence of obesity in COVID ARDS. So undernutrition and overnutrition are equally deleterious to the immune response. When we say about nutritional deficiency, we think about our pre-disease nutritional status. But it's important for us to understand that just like a pre-disease nutritional status, during the disease also, you can have nutritional deficiency developing. That's because of the prolonged nature. We know that COVID-19 is causing a prolonged hospital stay. If you have got a symptomatic COVID, it's not a disease that gets over 4 to 5 days. So decreased intake, decreased absorption, increased utilization, and increased excretion all contributes to it. So coming to the three superstars. So first, taking up zinc. We know that zinc cannot be stored in the body, and seafoods are an abundant source. So are the whole grains, beans, and nuts also contain zinc. So that means that you need a daily supplementation of zinc as a food, not exactly as a supplement. Zinc has very important immune function. In fact, zinc deficiency is associated with decreased function of the monocyte, decreased cytotoxicity, decreased phagocytosis of neutrophilic granulocytes, abnormal function of T cells. B cells undergo apoptosis. So on one side, you are having suppression of all the cell-mediated as well as the innate immunity. On the other side, zinc deficiency is associated with autoreactivity and alloreactivity. So a deficiency is a pro-inflammatory state. So again, why we are touching upon repeatedly on the pro-inflammatory state is that COVID-19 we know is a disease where virus per se is harming you, and also a hyper-reactive immune system is harming you. So we need to take care of both parts. And zinc deficiency, as we all know, increases the susceptibility as well as severity of diarrheal disease, respiratory tract infection, and other infections like measles, malaria, tuberculosis, etc. And what is the role of zinc in COVID-19? In vitro studies have shown that it inhibits SARS-CoV RNA polymerase. It decreases the activity of ACE2. And ACE2, we know, is the receptor through which the COVID-19 enters your body. It increases the production of interferon alpha, which is a very potent antiviral activity. And it has got anti-inflammatory activity. So having said this, it's very interesting to note that the risk factors for severe COVID and risk factors for zinc deficiency are incidentally the same. So does that mean we have enough evidence to say that the zinc causes a decrease in morbidity or mortality? This was a very recent study which was presented at ESPIS conference in September 2020, which showed that each unit increase in plasma zinc at admission to hospital was associated with 7% reduced risk of in-hospital mortality. They also showed that a zinc level lower than 50 microgram per deciliter at admission was associated with 2.3 times increased risk of in-hospital death. This was another small study from India of just 47 patients. But what is important for us to notice that 57.4 patients were zinc deficient. So zinc deficient in general population seems to be high, even though the worldwide zinc deficiency is taken as 17%. And zinc deficiency was associated with more complications, longer hospital stay, and mortality. But it's very important for us to remember that these studies don't confer a causal relation between zinc deficiency and occurrence of COVID. Because whatever studies we present now are the very small studies, single center studies, not RCTs to really say that this causes this. Only it means that zinc deficiency, COVID severity, and mortality needs scientific attention at the time. And before you jump on to the zinc wagon, we need to know that too much of zinc is not good. As Sir said, that zinc deficiency, too much zinc may inhibit absorption of copper, but too much zinc also impairs T cell functions. Zinc in concentrations that represent 7 to 8 times the physiological zinc. So that's good news. That is, you have a high therapeutic, you have a big therapeutic index. So slight increase doesn't harm. Too much of zinc can block interferon alpha, which is a very important antiviral activity. And zinc in dose of 100 milligram per day is considered as immunosuppressive. So that we have to take care. We are not looking at high doses of zinc. Now coming to the next vitamin, that is vitamin C. We all know it's an antioxidant with an immunomodulatory properties. But what is interesting regarding vitamin C is that a daily dose of 90 milligram is enough to prevent scurvy. But during time, if you want to prevent a viral exposure or physiological stress, the vitamin C need goes higher. So these are some of the studies, very interesting study published way back in 1978, a preclinical study done in chick embryo tracheal cells. They found that vitamin C increased the resistance to infection caused by coronavirus. And recently we had an RCT, which was carried out in USA in 167 patients with sepsis-related ARDS, indicated that administration of around 15 grams per day of IV vitamin C for 4 days was associated with decreased mortality. So this was a study which was published in JAMA in 2019. So thing that we need to note here is that the vitamin C used is very high dose and as well as it is parenteral. So Do we have any evidence in vitamin C and COVID ARDS? This was another small study of just 18 patients with COVID-19 ARDS, and they found that 94% had undetectable vitamin C levels. So does that mean these patients had scurvy or was really deficient of vitamin C? No, it doesn't mean that. It means that during times of extreme stress, there is an increased metabolic consumption, enhanced inflammatory response, high glomerular hyperfiltration, and often sick children may or adults may be on dialysis also. That decreased gastrointestinal absorption and decreased recycling of vitamin C contributes to this deficiency that happens in a critically ill patient. So that is why vitamin C is usually recommended, not exactly, as Sir has already said, meta-analysis has not really proven it to prevent an infection, but it may have decreased the severity of infection. And in critical illness, oral supplementation or routine supplementation does not have a role. It is only parenteral supplementation, and that too high dose. Again, it's a double-edged weapon, because too much of ascorbic acid may cause oxalate accumulation in the kidneys. Already 2 case reports of oxalate-induced kidney injury has been reported recently in COVID patients. So this can be prevented to a great extent by concomitant use of thiamine. So if there is no very great evidence for IV vitamin C, but if using, don't forget to combine it with thiamine. Now coming to the last vitamin, that is vitamin D. And vitamin D is a vitamin which seems to be the panacea answer for all malaise of mankind now. But we know that vitamin D can boost the innate immunity, and once it boosts the innate immunity, thus it can decrease the viral load, leading to a decreased overactivation of adaptive immunity. It decreases interleukin-6 and tumor necrosis factor alpha. An important finding is T regulatory lymphocytes are markedly lower in severe COVID-19 cases. Vitamin D supplementation can increase the T regulatory lymphocytes. So T regulatory lymphocytes are important for us to see that we are not responding with the cytokine storm to a severe infection. Vitamin D deficiency is associated with higher CRP and possibly increased risk of cytokine storm. So having said that, we have 2 recent studies. One has shown the retrospective case control study of 216 COVID-19 patients, where they found that the vitamin D level was lower in hospitalized patients compared to the basic population, general population. So probably it was increasing your susceptibility. Another study showed that these were patients who were not very sick. They were mildly symptomatic or asymptomatic patients, where they found that if a large dose of vitamin D was given, the patients turned negative earlier than those who were not given vitamin D. But earlier studies are there, which shows that chronic low dose is better than bolus dose in prevention of VRA. So if you're looking at taking vitamin D as a supplement to prevent a respiratory infection rather than bolus doses, it's a daily dose that is important, whether as a supplement or proper food intake is more important. Single large enteral dose does not improve outcome of vitamin D deficient ICU patients. The previous study was asymptomatic patients. In ICU patients, giving a large enteral dose has not found to increase the outcome, whether it is pneumonia or sepsis. So having said this, so what is the nutshell? There is no individual nutritional supplement will stop a person contracting the highly infectious virus like COVID-19. The best way to support your immune system is to maintain a healthy, well-balanced diet. Supplements cannot substitute a healthy diet. Overnutrition and undernutrition both may be deleterious. Vitamin C in high dose, vitamin D in normal dose, zinc supplementation may have a role. And so we don't have a single food which is going to help us. It is the multitude of foods and colors which is going to help us in this pandemic. Thank you.
Thank you, Dr. Sheeta, for that excellent narration of nutritional basis of immunity in COVID-19. Even though the 3 superstars mentioned by her, zinc, vitamin C, and vitamin D, it may not prevent a COVID-19 infection, but definitely there are enough scientific data which suggest these nutritional elements may decrease the severity as well as the morbidity and mortality. That is the message given by her. There are no questions in the chat box, I think. There are some comments about the excellence of the presentation. So thank you, Dr. Sheeta, for that great presentation.
Thank you.
Thank you, sir. Thank you, Dr. Sheeta. Now we move on to the panel discussion, Healthy Nutrition, Life Cycle Approach and Nutrition-Friendly School Services, including implementation of JUNC's guidelines. To chair the session, I invite Dr. M. Narayanan, President IAP Kerala and Consultant Pediatrician, Ernakulam Medical Center, Kochi, and Dr. T.P. Jayaraman, Dane Diagnostics, Palakkad, and President-elect IAP Kerala 2020. The session will be moderated by none other than Dr. K.E. Elizabeth, Professor and HOD Pediatrics, Sri Mookambika Institute of Medical Sciences, Kulashekaram, Kanyakumari District, and National President Nutrition Chapter 2017-18. The panelists are Dr. Rekha Harish, Dr. T. Himabindu Singh, Dr. V. Rajashekaran Nair, Dr. Satish Tiwari, Dr. Rupa Bellad, and Dr. Anish T.S. I request the chairpersons to kindly introduce the panelists. Over to the chairpersons.
Yeah. So, good evening. Healthy nutrition, life cycle approach, nutrition-friendly school services, including implementation of the junk foods. That's a topic for the panel discussion today. So we have the panelists. We'll be introducing the panelists in the beginning itself. So please share the slides. Ma'am, Dr. K. Elizabeth, you all know, I need not introduce her much, but she is PhD, MD, DCH, FIAP, and FRCPH also. Professor and head of the Department of SNIMS, Kanyakumari District, Tamil Nadu. And she is the former professor and HOD of Pediatrics and Superintendent, SIT Hospital, Government Medical College, Trivandrum. Madam was the State President of IAP Kerala 2016 and National President of Nutrition Chapter IAP 2017 and 2018. She has a special training in nutrition at NIN Hyderabad in 1990. At that time, I was a student at SIT Hospital. I remember that. And training in genetics at Leeds Teaching Hospital, St. James University, UK, and diabetes training at Teacher Exchange, Karolinska Institute, Sweden. She's an author of many books, nutrition and child development. Bloom is another book, and so many books and chapters she has written in renowned books of national and international publications. She is a recipient of the Best Doctor, Best Teacher, and award for the Best Research Paper also. And she has so many oration awards also to her credit. And Dr. Nirmala Kesari oration IAP Iycncon was done by her in 2018. Welcome, madam, to moderate the function, to panel discussion. Now, the first panelist, Dr. Satish Tiwari, is the founder president of Indian Medical Legal Ethics Association, and is the founder convener of Human Milk Banking Association, and founder secretary of Medical Legal Group of IAP, founder secretary of IYCF chapter of IAP, and professor of pediatrics, Medical College, Amaravati. He's also done the Dr. Nirmala Kesari oration in 2012, and Dr. Was awarded the Dr. Hmbcon award in 2015, and he has done other two orations, Dr. Shirol oration in 2019, and Dr. Ghoshal oration in 2019. Dr. Satish Tiwari is the National Executive Member of IAP in 2007 and CCC member of BPN in 2006 and 8, and was the president of Maharashtra BPNI in 2004 to 2006. And he has edited so many books and medical legal and textbook on medical legal issues. Welcome, sir, to the panel discussion.
Hello. Hello, Narayan.
Yeah, you can, Dr. Jayaraman, please.
Yes, thank you, Dr. Riaz and Dr. Anju, for inviting me for this session. And I'm very happy to introduce Dr. Rekha Harish, who was Vice President North Zone of Indian Academy of Pediatrics 2019. She had been a member of the National Executive Board of Indian Academy of Pediatrics several times, and she was professor and head of the Department of Pediatrics, Government Medical College, Jammu, and presently she is in the head of the Department of Pediatrics, HIMSR, New Delhi. And she was president of Non-Communicable Disease Prevention Academy, which is IAP chapter, and she was a member of Non-Communicable Disease Technical Advisory Group, Asia Pacific Pediatric Association. With these few words, I am very happy to introduce Dr. Rekha Harish as our panelist to this session. Thank you. And
Dr. Rupa Bellard, she's Director Academic Affairs, KLE Academy of Higher Education and Research. She's a professor of pediatrics, Kahas Jain Medical College, Belagavi, Karnataka. Her areas of interest include infant feeding, medical education, and human milk banking. And she has done a lot of research studies involved in international research areas in child health and many other international research programs. And to her credit, there are more than 20 publications in international journals. Welcome, ma'am, to this panel discussion.
I'm very happy to introduce Dr. Himabindu Singh. She was along with me in the National Executive of Indian Academy of Pediatrics in 2014. And she is presently Professor and Head Department of Neonatology of Osmania Medical College, Hyderabad, Telangana. And she's a Nodal Officer of UVA, which is a Center of Excellence in Adolescent Health, Nilofer Hospital. She has done so much of work in adolescent health, and she was President of Indian Academy of Pediatrics, Twin Cities Branch, 2013. She was President of National Neonatology Forum, Andhra Pradesh State in 2008. And she was Organizing Secretary for a number of conferences, Iycncon 2008, Iycncon 2013, and APA Pedicon 2016, Pedicon 2010, and Neophobia 2013. And she has been a member of Indian Academy of Pediatrics National Executive Board for 3 terms, and she was a national convener of Pediatrics IAP Women's Wing. With these few words, I'm very happy to introduce Dr. Himabindu to this group. Thank you.
Dr. Jairam, please.
Yes, I'm very happy to introduce Dr. Rajesh Nair, who was Professor and HOD of Obstetrics and Gynecology, Medical College, Trivandrum, and HOD of Department of Obstetrics and Gynecology, SUT Hospital, Trivandrum, and he was a Dean of Kerala University of Health Sciences, and he was past President and Liaison Officer of Kerala Federation of Obstetrics and Gynecology. Welcome, sir, to this panel. Thank you.
Yeah, we have Dr. Anup T.S. Dr. Anup is a teacher and researcher in public health. He is Associate Professor, Department of Community Medicine, Government Medical College, Thiruvananthapuram, and also he is the Administrative Medical Officer, Integrated Family Health Center at Pangapara, Thiruvananthapuram. He has got more than 35 research publications with 430 citations in indexed national and international journals, to his credit. And he has so many other achievements, like he is recognized as a PhD guide by Kerala University of Pujas under Faculty of Modern Medicine. And he has received some awards also for his papers. Welcome, Dr. Anish, to this panel discussion. It's over to Dr. I think Dr. Jairam.
Yes. Excuse me, I think you can introduce the topic, Narayana.
Right, for introducing the topic and further this thing, I hand over the mic to the moderator. Thank you.
Thank you, Dr. Narayanan and Dr. Jayaraman. I think so. My plea is that thank you all the panelists. Also, my plea is that please fasten your seat belt, because we are going to take you for a ride all throughout the life cycle approach and the first areas of nutrition, starting from the foundation, the first 1,000 golden days of life, the revised definition for infancy. Now it is up to second birthday is considered as infancy. Early infancy is from 1 to 12 months, and late infancy is 12 to 24 months. That is to cover the breastfeeding period. Then toddlers, the terrible trees, the preschoolers, the school child, and the creamy layer adolescents. And we have moved from Iycn to Iycn. Now that it has landed up with the Iyccan, that is maternal, infant, and young child and adolescent nutrition. Let us start with the breastfeeding, which is the strength and warmth. And I couldn't find any better picture. That is the love and the warmth and whatnot, the immunity, the brain growth, everything imparted to the baby from the mother. I think the WHO data is an eye opener. It was an eye opener to me. That is, if you delay breastfeeding for 1 hour, that is 2 to 23 hours, there is 33% higher chance of dying within 28 days. And if it is delayed beyond 1 day, 200% chance for child, the risk of dying. So my question is that how many of us insist on recording the first feed in every newborn baby? We record the first cry, the first meconium, the first urine, etc., etc. But I think that if we start recording the first feed in every newborn and why it could not be started within an hour, and that itself will make a big intervention. And the National NFHS survey for 2015 to 16 showed that early initiation is as low as 41.6%. Now, I would like to ask Dr. Satish Tiwari. He is the apostle for breastfeeding and the IMS Act. Breast milk is a lifesaver to millions of infants. Still, why we are not capitalizing on it? Why do we fail in achieving the goal of early initiation soon after birth beyond 50%, despite majority being hospital deliveries?
Thank you, Elizabeth, madam, for this opportunity. And I think the reason why we are not able to achieve the early initiation. Now we all know that early initiation is best start in the life. It gives skin to skin contact. It increases the long-term secretion. Feeding problems are less in future. The breast related problems are less. And according to many of us, it is the 4th stage of labor or the 8th para during the marriage which should be taken. Breast milk is species specific as well as gestation specific, and we know the human milk contains only 1 gram per 100 ml while the rabbit milk contains 15 gram. Next. And breastfeeding is also natural, tailor-made for the baby. Babies need mom-made and not man-made. And for early initiation, we can start the feeding by breast crawl, even in LSCS babies. The early initiation decreases the mortality by 16% and proper complementary by another 6%. So total around 22% of mortality under 5 will decrease with proper breastfeeding. In spite of this, even the WHO says that the breastfeeding is the best, and in the absence of breastfeeding, the option is express breast milk or donated milk, and there is no advantage of artificial feed. As you rightly said, according to NFHS 4 data, initiation in first hour is only 41.6%. And the reason for all this is that, now this is the most important part which we have to understand, that there is a lack of collaboration between obstetrician and pediatrician. The mother and child diet, which should be kept as a single, is divorced. We are too busy to discuss with the parents or the mother. There is no time to discuss with the relatives. At the same time, there is a lot of unscientific, biased and misguided information available to the parents or the relatives. Lactation failure is accepted as a common problem, and we leave no attempt to decrease the mother's confidence, while actually we should build the mother's confidence. So we have all failed in our responsibility in promoting the breastfeeding.
Thank you, Dr. Satish Tiwari, for that excellent learning experiences even from the animal kingdom. So in the animal kingdom, we see a passive mom and active babies. So when are we going to make the babies active so that they can crawl to the breast? Now we put them in the most helpless manner, that is the supine position, when the mother has to do everything, the active mom and the passive baby. That is the rule that we follow. We have to go back to this passive mom, active baby rule. And we have to think out of the box solutions. Baby-led breastfeeding and breast crawling was highlighted. Sometimes we can even go for areola feeding in flat nipple and alternate hold. See, the U hold may help and the cross cradle also may help. See, this is how the baby-led breastfeeding is done, and this is the cross cradle method that we can follow. Now, Dr. Sadish Tiwari, what is the role of industries in this contest and the power of IMS Act as a remedial measure?
As we discussed that there has been a lot of misinformation and wrong information by the industry and by many of our colleagues also. So keeping this in view, the Indian government came with the IMS Act in 1992, and though it was not that effective, then it was amended in 2003. So now we have amended, and according to this amended IMS Act, for the violation of the various provisions of this Act, there are penalties which include imprisonment and fine up to 5,000 rupees. Still, what is happening, there is lot of violation of IMS Act. We can see these photographs. Many companies, they are sponsoring the seminars and webinars for our colleagues. The pharmacy stores, they are full of formula milk or with the animal milk and the options of bottle feeding and the various cereals. And because of this, because of there is limitations of IMS Act, it is for infant food up to 2 years, which should not be used according to IMS Act. But unfortunately, we find that it is used after 6 months of the age. In the pharmacy or chemist, it is over-the-counter sale continues. Monitoring and follow-up by our own colleagues and others is not satisfactory. And that's why these companies are breaking the law, not in only in words, but also in spirit. There are many pediatricians and our colleagues and obstetricians which have become voices of these IMS Act companies. They promote the IMS Act product and their sponsored programs, and that is why the Act is not taking what it should have been done. So what we have to do, we have to promote this Act, we have to promote and support the breastfeeding, and this we have to do with activism and a proper guidance. We have to keep in mind that because God cannot be everywhere, that's why He created the mother, and even in twins, we can have exclusive breastfeeding. So finally, the carry-home message is that breastfeeding is natural, instinctive, and physiological. It is mother's as well as child's birthright. There are no advantages of artificial feeding. Rather, there are definite disadvantages of artificial feeding. So we should not be blind followers of the Western countries. The parents and health workers concept must be clear. And we have to remember that only law is not the answer. We have to be very effective activists to protect, promote, and support the breastfeeding. What I would like to summarize with, give the world the best you have. It may not be enough, but still give the world the best you have got anyway, and give this tiny treasure the best start in the life with human milk, that is the breast milk. For this, we have come together with these various organizations. So coming together is beginning, keeping together is progress, and working together is success. Alignment has been one of the most important, our partner. They are sponsoring today's, they have provided us the platform for this webinar and the conference also. So I think we have to work together to get the success. Thank you.
So the story is that no matter how long you have traveled in the wrong direction, we can always turn around. Thank you, Dr. Sadish Tiwari, for that quote also that you gave. So now we are moving to another area. Children are not small adults, as caterpillars are not small butterflies. Nutrition during the first 1,000 days of life is the foundation for physical, mental, emotional, and immunological well-being. But still, exclusive breastfeeding is happening only up to 6 months, only in 54.9%, and complementary feeding is appropriately started only in 42%, and adequate complementary feeding, as Dr. Priya was telling, is seen in only 10%. Now, my question is to Dr. Ruba Ballard. Why exclusive breastfeeding in the initial 6 months is so low, even after succeeding to ensure 6 months paid maternity leave in the organized sector? And why continued breastfeeding till 2 years and beyond is suboptimal?
Yeah, good evening, madam. And at the outset, I would like to thank you and the other organizers for giving me this opportunity to be part of this very prestigious conference. Yes, as we are all been aware that the rates, especially the breastfeeding rates, are very suboptimal. And we cannot go on. I mean, the reasons are multiple. It is not just one factor we could state which would contribute to this particular practice. But when we start asking the mothers, the common reason which comes in their mouth is, I don't have enough milk. And that's where I think we need to help the mothers. All the mothers are aware about the advantages and benefits of breastfeeding, complementary feeding. But when it comes to practice, especially when they move on to the home after discharge, between 4 to 6 months, we are talking about exclusive breastfeeding. There's a lot of difficulty which comes up during breastfeeding, and that's where there is lack of support. And this, I think, is the main reason today that in the community, even though we are having family members in the households, or we have ashas, we have health workers, we have so many programs, I think the hand holding of the mothers is not very not up to the mark. And I think that's one of the reasons. I'm just not stating it. We have conducted a research, the community-based research, where we wanted to do intervention to improve the practices. So we did a qualitative survey, focus group discussions with the mothers, the household members, healthcare workers, and the main reason they stated was lack of support in the community. And we did follow this with an intervention, that is, we had peer counselors and we gave them a multimedia mobile app, and they did the support to the mothers. And this actually it was amazing to see how much the breastfeeding rates improved. So I think that's the main reason. There has to be some system where the support to the mothers can be given to improve the feeding practices.
Thank you for that very practical solutions. So what about breast milk banking and the role of CLMC? So we hear about CLMC, LMC, LSU, etc. Can you enlighten on that?
Yes, ma'am. As we know, we in India have a large burden of largest share of births when we compare to the world statistics, and so the neonatal deaths. We have 30% of the neonatal deaths in the world. So we know that the National Health Mission has come up with various strategies to improve the mortality and morbidity, that is to decrease the morbidity and the mortality. And strengthening, promoting, protecting breastfeeding is a critical strategy. And human milk, we all know, has a lot of advantages in improving the health status of these babies. Next slide. So protection provided by the feeding of the breast milk, especially during sickness, is very much important. We know that. But there are certain circumstances where the preterm, low birth weights and sick babies admitted to the health facilities do not get their mother's milk. There are many situations like that. So there is a need to provide continuous supply of safe breast milk to all these babies admitted in the health facilities, so that we improve their survival and the well-being. So this health-based lactation management strategy, which has come up, has comprehensive lactation management center, very good strategy being brought up by our government, is going to make universally the availability of breast milk to all these babies, especially for the sick babies. And it's this innovative strategy has been tested all over the world, and they have shown us that this brings down the infection rate and improves the survival of these small babies. I think that's the relevance of comprehensive lactation management centers in our center. And of course, we look at the data. We have a huge burden of preterms, low birth weights who require this milk if mother's milk is not available. And so donor milk plays a life-saving role to help these babies to survive. Yeah, this is the Comprehensive Lactation Management Center, which has basically 4 principles, 4 support systems. One is, of course, first and the foremost is supporting breastfeeding, showing the mothers how to breastfeed, tackle all the challenges in breastfeeding, and encourage healthy mothers to feed their baby, excess milk to be donated, and donated milk to be processed and pasteurized and to be fed to these mothers who require where their mother's milk is not available.
Thank you, Dr. Ruva. I think you have rightly said the biggest challenge is that the baby-friendly hospital initiative is applicable only for 2 days in term babies and 5 days of hospital stay in cesarean babies. Afterwards, what? Actually, in 2016, the government of India started the MA program, Mother's Absolute Affection Program, for creating awareness, community intervention, and monitoring. But it did not take off in a big way. So we have to start that. And in 2018, we saw the Rajasthan government passing a law telling that no discharge from hospital if woman is unable to breastfeed after delivery. I must say that in Trivandrum Medical College SAT Hospital, Dr. Shobha Kumar, our neonatology head, she was insisting on this. And even when there was an abandoned baby who had to go to the social justice department, the care home, she used to insist that the staff should come, stay in the nursery and feed the baby, and then only she will send the baby. So I think hats off to her for that. Now, over to Dr. Himabindu Singh. Roughly 1 out of 2 babies get semi-solids by 6 months of age, and the transition to family pot feeding by 1 year of age is very low. What do you think are the issues and the solutions?
Very good evening, madam. Thank you, Madam Elizabeth and the whole team at Kerala Trivandrum for organizing this wonderful conference very close to our hearts. And thank Dr. Satishji and the IYCF chapter for giving me an opportunity. Well, I think this is again, as Dr. Rupa has already highlighted, breastfeeding is really a challenge still, and we are also doing a lot of QI initiatives to initiate breastfeeding, and we were successful at, to initiate breastfeeding in the labor room itself through a QI called Mission Shigra, by putting a stamp on the case sheets and discharging them. Without that, the child is not discharged. Coming to complementary feeding, this is another challenge. Though, we all say that, yes, it has to be started after 6 completed months and what sort of food to be given. But I think these are the few things that still there's so much lack of knowledge among our parents. And they still, even not just the uneducated or the lower socioeconomic status, even the educated parents have still been confused when to start the complementary. They still feel it's 4 months. They still have that feeling that breast milk is not enough for the 6 early months of infancy. So they feel that my child is just taking breast milk, they don't see how much is going in. They have a feeling that my child is not growing, maybe I need to add something. So regarding either they start early, that sort of problem is there, or some of the mothers, they start quite late. By 9 months, 10 months, still they are only on breast milk. So there's lack of knowledge about when to start. And they also give some, if they start, they feel, the child cannot digest complete the whole food, and they start with some juices and then very watery foods like dal water, rice water, which is not adequate in calories. So these are the reasons, and this could lead to definitely undernutrition. And we have all seen that even though the breastfeeding is going on well, and they suddenly drop between 6 to 9 months. We have seen the road to health charts, and this 6 to 9 months is a very vulnerable period. If the child is not started on proper complementary feeding, we have seen undernutrition in these children. So I think the solutions are definitely parental education, and we have to talk to them to continue breastfeeding and to start proper, nutritious, locally available complementary feeds, not that over-the-counter dabbas or the, whatever, I don't want to name them, but they're very easily available and they feel that is the right food which will give, the weight gain for the child. We should talk about the good nutritional foods which are locally available, and even the art of feeding is very, very important. Many mothers force feed them and they don't allow even the developmental milestones, the hand-mouth coordination, and they have the critical window is there where the different tastes have to be introduced and lumpy food has to be introduced. All these things, the knowledge is not there. So the improper feeding habits and the responsive feeding is not there in most of the children. So they may also have failed to have proper complementary feeding. And so a lot of myths are also associated with this complementary feeds, hot foods, cold foods. So I think we need to really go through a good parental education programs and actually practically helping them, like as breastfeeding. We need to handhold this parents, and even in the Anganwadi or in the community or when they come for hospital visits, we should utilize the opportunity through the IYCF centers. We should have the CLMCs can also take care to give this practical tips.
Thank you, Dr. Himabindu. As you have rightly said, how the thickness, it should not fall off from the spoon, and the density of the food also. Breast milk, roughly 70 kilocalories in 100 ml, and the complementary food is supposed to give 80 to 100 kilocalories per 100 ml or 100 grams, whereas the dilute food is going to give only 30 kilocalories. And Dr. Priya had also reinforced that 20 ml per kg is all what they can take, and it should be energy dense, nutrient dense, and how to increase the calorie and the nutrients by adding oil, ghee, jaggery, and germinated foods, etc. was highlighted. And even when a baby is breastfed, roughly 500 ml of breast milk is going, see the energy gap happening from 6 months to 9 months to 23 months. And see the iron gap. Very little iron is there in breast milk, but it is 50% is bioavailable. But when the stores are gone after say 6 months, the iron gap also widens. And this shows that in the second year of life, even when complementary foods are given, there is an energy gap, protein gap, iron gap, vitamin A gap. And see here, that is foods and snacks are given, but no breast milk. Again, there is an energy gap, and breast milk and 3 meals are given, no snacks. Again, there is a gap. So there should be a transition to family pot feeding with 5 food groups, 5 colors, 5 times in rotation, along with breastfeeding. And we have redefined infancy up to the 2nd birthday. And Dr. Himabindu Singh, again, picky eating disorders in children is a big havoc. How to approach?
Yeah, ma'am, this is something another area where many of the parents come to us and saying that my child doesn't eat fruits and vegetables and he's very picky and choosy about, he wants only sweet items, he doesn't eat this, that. There's so much concern. So picky eating is nothing but the child is very fussy, he does selective and choosy eating, and he rejects the familiar foods, and he may also have neophobia. Neophobia is something which, rejecting new foods, which is not familiar to him. So it's a very common behavior in early childhood, ranges from 6 to 50%. Usually in the 2nd year it peaks, and by 4th to 5th year this picky eating may go off. But if it is persistent, may lead to a lot of problems later. So it may be due to early feeding difficulties or late introduction of lumpy foods and the pressure to eat. When you tell them, please, this has to be avoided. And definitely picky eating may lead to, it will definitely lead to micronutrient deficiency, especially iron, zinc, selenium, and vitamin D. And the dietary fiber is also low because these children tend to eat less of fruits and vegetables. And if this is persistent, it may by 5 years, it usually child may come back to normal eating, but if it is persisting, may lead to a developmental difficulty, and may in adolescence also may lead to thinness and stunting. So we need to approach this children quite early. I think by just taking a history about the diet content and what they are for family dynamics, they are feeding dynamics, how it is. So even the history of constipation will tell us that the child is not eating enough of fiber. So this history should be taken, And when you examine the child, see, most of the children may have a normal weight trajectory because they may have, they may be good in calories and proteins, but not good in micronutrients and fiber. So we have to look for micronutrient deficiencies, anemias, and if they weight and BMI also need to be checked, but some of the scales are there which are validated. Questionnaires can be followed, and then we need to manage them by counseling, especially parental counseling, educate the parents about early introduction of these foods, especially the fruits and vegetables, and having that all of them eating together, the family pot, that is very important to set the right messages to the child. And this including the bitter taste, and all the foods need to be introduced quite early. It's not just the sweet foods. So this will help them, and the feeding should be without any pressure. A responsive feeding habit should be introduced to the child. Now, this eating disorders, these are little major health problems. This is a major mental health issues actually. So typically seen in adolescents, which females are more prone. There are typically 3 types: anorexia, bulimia, and binge eating. We all know about anorexia nervosa, which is actually eating disorder characterized by abnormally low body weight. Though the girl is very thin, and because of body image and other issues, she feels she's actually fat, and she has an intense fear of gaining weight, and they may develop strange eating habits. They avoid, they very monitor every bite they're eating, and they may go for excessive exercising and rapid weight loss techniques, and they may be associated with other mental health issues like anxiety and depression. So these children need to be seen by a psychiatrist. We can definitely help them, pediatricians, by at least looking at the early signs and symptoms, and take the help of a psychiatrist, support feeding, and then we need to go for CBT and medications also if it is quite associated with anxiety and depression. Bulimia is an emotional disorder. Here the child is actually binges and then vomits after eating. We can suspect when the child is spending a lot of time in the bathroom, and they have body image issues also. They may use laxatives, other treatments to prevent weight gain. Associated with anxiety and other disorders may be there. Here also the treatment is again counseling. Psychiatrists may be help may be required. Antidepressants, behavior modification. Family has a big role to support, and nutritional counseling has to be done. Binge eating, they eat a large quantities of food, but without purging. And this also requires a behavior therapy, medications, and psychotherapy. So we all need to know about these eating disorders because they are quite common. It's not so uncommon in India, though we feel that is only these disorders out of developed countries, but we are seeing very, very commonly nowadays in India too. So we need to be aware of all this.
Thank you, Dr. Himabindu, for that excellent narration of all the eating disorders. I think what she mentioned is the responsive feeding. We should promote responsive feeding and avoid non-responsive feeding. There are 3 types of non-responsive feeding. One is the indulgence type, where the child controls the feeding situation. And the second is the uninvolved type, where the caregiver ignores the child during meals. The third is the pressurizing or the controlling type. All these 3 are not desirable. It should be a pleasurable thing, a family time for the child, and not and in a media-free zone, in a media-free time. So, Rajshekharan sir is our professor who taught us obstetrics and gynecology. Sir, adolescent girls' eating patterns among prospective mothers are also not optimum. What are the reasons and the solutions?
Thank you, Dr. Elizabeth, Dr. Indumati, and all the other members of the organizing committee for permitting me to share some thoughts on these very, very important topics. As you know, if you look at the dietary patterns among the adolescent girls, a lot of things could be identified. For example, one of the very common thing will be snacks, use of snacks, usually energy-dense food while watching TV or while doing the very common, especially the breakfast. Once you skip the breakfast, the whole pattern of intake on that particular day is upset, resulting in irregular meals. And this result in wide use of fast food also, because there is no botheration for cooking. And the access also is very easy in our Swiggy, Zomato, everything is available so that you can get food within no time. Then overuse of chocolates, sweetened drinks, too much calories and preservatives also are ingested. Along with this, you find that there is a low consumption of fruits and vegetables. So ultimately, lack of physical activity leading on to obesity because they are consuming a lot of unaccounted calories. And it has become, just like an epidemic, it has become very serious in states like Punjab and Kerala. Kerala is second to Punjab. We find that nearly around 15% of school-going children are either overweight or obese. And if you look at the government sector and the private sector, you find that affluence play a major role. That is, private schools, you find that the overweight and obesity. I think all these should be viewed very seriously in the light of increasing use of the junk foods. And when you come to the pregnant women, we find that in our hospitals, nearly 60% of these pregnant ladies are either overweight or obese. Naturally, a myriad of complications can be anticipated. The GDM was hardly 3% while I was doing my post-graduation. Now it is almost 30%, tenfold increase over the course of around 30 or 40 years. Like that, hypertensive disorders, then labor problems, the tardy progress of labor, difficult cesarean, a lot of complications. And even the aftermath is passed on to the next generation as the metabolic syndrome. So I think the pregnant women, there is an increased craving for such food also. And the nuclear families tend to promote such eating pattern. And another thing which has come up recently is the changing working pattern, because most of these women are working from home. So again, the eating pattern also is changing, and ready access to the online food chains also another very undesirable thing. And how to control, I think it's rather a difficult job, because the wide propaganda for the junks happening through the visual media. Every 1 hour you find some sort of an advertisement, either for the Pepsi or for the pizza and all those things. So it's very difficult to convince people about the advantages of the natural thing. So to start with, I think we should advise on the breakfast on time with a good start. Everything will be taken care of. And it should be emphasized that a lot of milk, egg, fruits, vegetable, etc. should be included, along with the adequate exercise. And a big no to junks. And these are some of the things which I should emphasize at this point. Thank you.
Sir, that was very practical solution that you have given. Regarding nutrition related issues in pregnant and lactating mothers, what strategy will work?
I think you may notice that the field of midwifery has been witnessing a lot of medicalization as well as commercialization in the last 2 or 3 decades. And there is no wonder that we tend to overlook very basic issues of pregnant women, such as breastfeeding, and message across to the parturian, that is, your eating habits will affect the baby. Without any ambiguity, you like to tell them that this is the sequelae which is likely to happen if your eating habits are abnormal. Okay, this can be during consultation. Then it can be displayed in the hospital waiting area. It can be included in antenatal cards, etc., etc. And these ideas should be reinforced every time with appropriate IC materials. And it is equally important that the family members should also be involved in such activities. Otherwise, it will become an ineffective exercise. And we have to emphasize on the good quality, good healthy eating habits, and the utilization of locally available seasonal resources, which are very important nutrients by way of minerals, vitamins, etc., along with the supplementation of calcium and iron. And so we should utilize every opportunity to educate. But at the same time, we should not scare them, because an occasional piece of pizza or a burger is not going to be a crime. So to summarize, I should say that a voluntary effort on the part of the clinician is needed to control the increasing use of junks so that the next generation will be more healthier. Thank you, Elizabeth.
Thank you, sir, for enlightening us on the transgenerational effect also. I think this chart is very interesting, which came up from Institute of Medicine way back before the turn of the millennium. That is, the weight gain during pregnancy should be based on the pre-pregnancy BMI. I think still the knowledge and the teaching is that 10 to 12 kg is okay. See, underweight mother can gain 12 to 18 kilograms, whereas the overweight need to gain only 6 to 12, and the obese, it is put to 6.8 kilograms. So this information is also seems to be very important to be passed on. So now we have the public health man with us, that is Dr. Anish here. Dr. Anish, please outline the nutrition related programs in our country.
Good evening all. First of all, I would like to thank Ma'am Elizabeth Mann for this opportunity to stand before the wonderful audience. So I am actually coming from public health. Public health has got so much diversity across India. When I am sitting in Kerala, that will be very much different from a person sitting at Bihar. But for a clinician, that kind of a diversity may not be there. Look at the health status of our country, or what we have achieved maybe last 10 years. So it is actually a marginal difference. Maybe in Kerala it is too marginal compared to an average Indian state. So we have got a lot of public health programs with us, but we are not actually making up to the mark. Out of the 5 national social security schemes, 3 are directly nutritional program. It is something good, but something bad also, because why you are keeping nutrition as a heart of your social security, that means you are not able to take care of other things. Nutrition is a basic parameter. That means even the basic parameter of our people is not addressed. Out of the 5, midday meal that we know, and it is actually a wonderful program that is there maybe all over India. ICDS, even though it has got some issues, for example, it may be taking care of children and pregnant mothers and some part of the lactating mothers also, but it has introduced the feeding program for adolescents and elderly, but it is very patchy. And PDS, what happened to PDS? That is provision of provision of food materials for our poor people. What happened for the last 20 or 25 years that our ration shops are becoming just like they are becoming nominal in giving away food materials. Another 4th program is Mahatma Gandhi National Rural Employment Guarantee Scheme. Even though that is an employment guarantee scheme, it is a nutritional component in it because it is related to the first Millennium Development Goal, that is eradicate extreme poverty and hunger. Why you are giving occupation or employment to just feed our people? So in a way, out of the 4 programs are related directly to nutrition, and only 1 program that is left is the pension scheme. And now something positive is happening, that is this portion, that is Prime Minister overarching scheme for holistic nutrition Hmbcon, that is otherwise known as National Nutrition Mission, that was started in 2018, is an overarching program, just like that of NRHM that comes to health system. There is another program is coming up, and it will integrate all other programs along with the programs that we have discussed. Vitamin A prophylaxis program, universal iodization program, and all these things will be there in a loop so that it will be functioning much better. That I think. Next slide, ma'am. And here we can see the anemia, because out of the micronutrients, iron may be the only micronutrient that we address as national programs. And we know that, again, what is happening to our rates maybe in the last 10 years. So again, we are actually making very marginal changes in the iron deficiency. So we are integrating the whole programs that is available in taking care of iron deficiency. That is, we have got Anemia Mukt Bharat by integrating all of the programs. But still, we have to think that we do not have much programs maybe for a vitamin B12 deficiency. Even though iron is coupled with folic acid, that is much cheaper. But vitamin B12 is not able to be given to our people. So, and other vitamins like vitamin D, vitamin C, and all other things are not actually given for our people as in a public health program. That is a real concern for us.
Thank you, Dr. Anish. So what are the strategic changes that, as a public health man, that you would suggest for high impact programs that you have discussed?
Ma'am, still we have got, this is another publication that it's a small publication that we have, and we suggest a multitude of interventions, policy intervention in the next slide. So I am going for the some of the slides that we are already addressing, and I am not going to that. We look at the last one, the community approach to nutrition. For example, in Kerala, what is happening to ICDS and what is happening to midday meal program, because our Panchayat Raj system is very strong, the Panchayats are giving additional food materials other than grains. For example, they are giving egg, they are giving green leafy vegetables to ICDS units, and the children are fed with these kinds of vegetables and fruits and all other things. That is one model that we can use maybe other part of country. Sometimes it may be happening in other part of country also. Another thing is we have to use the cutting edge evidence for our nutrition related program. Still we are giving elemental iron for maybe our iron anemia program, Bharat program and all. And there is a lot of evidences are coming out that there is elemental iron is not going to be absorbed from your intestine, and it is going to hinder the microbiota of your intestine, and sometimes it may be poisonous to the healthy microbiota. So we cannot address a food deficiency using an element like iron. If the food materials, if there is a deficiency of food materials, we have to address it with food. So that kind of things you have to incorporate in our program. And the effective utilization of available food delivery system is another thing that we have to use. So these are the things we have to incorporate. The first three things I think we are incorporating. And a lot of questions are there that is unanswered question in our nutrition related program. For example, something related to our normality. Even though we are saying that 60% of our women is suffering from iron deficiency, what is our normal iron? That is actually another question. Even though in our day-to-day practice, we are seeing that maybe 90% of our population is vitamin D deficient. Is it real vitamin D deficiency, or is it because of some other normality is there for Indians that we do not know? Another thing is, can we address the dietary deficiency using tablet that I have already another thing is, do we have granular data that, for example, we are giving iodized salt for each and every person in our country, but in our coastal area, the land itself contains a lot of iodine, and even the food they eat also contains a lot of iodine. The iodine, over intake of iodine, just like that can happen in case of vitamin A in an affluent child. If you take overnutrition, what is going to happen? These kinds of things should be communicated to the community, and there will be a granular difference. Whatever things you are given in a deficient area or in an area that is marginalized may not be different from an affluent area. That kind of changes in granularity should be there. Another thing is, still we are focusing on grains for our food programs. We have to add more fruits, vegetables, and all other food materials containing micronutrients. Even we have to address food preferences also. So these things should be addressed, and we have to go for a real life cycle approach, because as more and more people are there, elderly people are there in our community. As our community is shifted to the elderly age group, we have to concentrate on the food choices and food availability of our elderly people also. So these kinds of strategic changes should be there to be in our national programs. Thank you, ma'am.
Thank you, Dr. Anish, for that nice overview. I think in most of the pediatric sessions also we hear that vitamin A, like massive doses, 9 doses to everybody is not needed. It should be a targeted approach like that. Or most often it is in paper only. When people go there, they say there is short supply, etc. And I think the iron gap, addressing iron gap, Dr. Anish was stressing. Delayed is something what somebody should mute yourself. Naveen, please mute yourself, Naveen. So delayed cord clamping is one, promoting breastfeeding, biannual deworming, dietary diversity, then avoiding anti-nutrients is also very important. But we were focusing only on supplementing IFA. And it was 100 milligram iron which was given to a 25 kilogram child in the school health program. And it was so much overdose. Now the government has come out with the, instead of the entry coated to sugar coated 60 milligram. And for pregnant women, from 100 tablets, it has been raised to 180. For lactation also 180 tablets. Then bi-weekly iron is now encouraged to be started from 6 months onwards. Then junior WIPS for school-going younger children. Then WIPS program. Each tablet has got a different color, and also WRA, that is women in the reproductive age group. I think more important than that is that we should understand and study what are the normal hemoglobin cutoff levels. 9 and 10 is not normal. It is 11, 11.5, 12, etc. So that should be studied. And the iron-rich food. And when we think of iron-rich food, most of the vegetable sources are less bioavailable. The heme iron is better absorbed. And anti-nutrients. We used to think that taking an amla will help us because it has got a lot of vitamin C. But now the NIN study says that amla has got a lot of polyphenols, which is the antioxidant, which is an anti-nutrient to iron. They say that we can take a guava will be better than the amla for promoting iron. And iron and vitamin C, the ratio also should be there. Phytate to iron ratio should be there. And looking, as Dr. Anish was mentioning, looking beyond the palm is also very important. This sort of pigmentation tells us about megaloblastic anemia. B12 is a big problem, especially in strict vegans. And if the mother is deficient, it can be a big problem in the younger baby also. And this is the 6x6x6 strategy. 6 beneficiaries, 6 goals, 6 interventions, 6 institutional mechanisms. You can go to the website and download it. And the Global Hidden Hunger Index was, for the first time, it was defined in 2013. And see, Sub-Saharan Africa, India, and Afghanistan. These are the only 3 places where it is alarmingly high. That is, it is a cumulative index of zinc deficiency, which is chosen as an indicator for stunting, then iron deficiency anemia and vitamin A. So where are we? We have to move a lot from this. Now we go on to another area, that is the lifestyle diseases, the junks and all. So over to Dr. Rekha Harish. Summarize the IAP junks guideline and discuss the role of general pediatrician in the practical implementation of this. Over to Dr. Rekha Harish.
Wonderful invite and helping me in learning nutrition basics from you and your team today. If you want me to summarize junks in a short span of few minutes, I'll just touch the brief salient points. In the era when the day starts in the morning with cereals, ready-made cereals, and health drinks, it lands in the school canteen. I'm talking of a child. Then the child lands in the school canteen with something, whatever fancies him, a burger and a Coke. And then he comes back and the parents are not there. He watches TV with the pack of chips and chocolate at home, prefers not to eat food, and then rushes to tuition and comes back. And sometimes when he is performing very well in academics, his dada, dadi, nana, nani, they are ready with chocolates. So in this era, when the every environment is so congenial or so obesogenic, we are talking of junk foods. The first junk food which should strike our mind is the what Dr. Satish Tiwari said, comes under IMS Act as the tinned milk or this thing. Then come the tinned cereals. And the nutrition chapter of IAP took this lead under leadership of Dr. Piyush and Dr. Elizabeth also, that they would like to define actually what is junk. To club all the unhealthy foods together, they designed the acronym JUNCS, which comprises of not only food high in fats, salt, and sugars, but also the ultra processed foods, the nutritionally inappropriate homemade foods, the caffeinated, carbonated, and the colored beverages, and the sugar sweetened beverages. So that is why they try to find out evidence which is in favor of these statements, the recommendation, and many of them for which this scientific evidence was not available, the consensus statement was made. So for as we see, for caffeinated drinks, we had a limit. No caffeinated drink till 5 years of age, and then 1 cup a day. But when we talk in terms of caffeine, we have to take into account the other products also which the child is taking. Some chocolates, some cola drinks, and so many other energy drinks, they are full of caffeine. And when we are talking of the child, he has consumed the caffeine in total. And we are well aware of the caffeine toxic effects and the side effects. Then when we are talking of fruit juices, or what to talk for beverages, water is supposed to be the best drink. Whole fruits have to be encouraged, and they should be encouraged right from 6 months of age. Fresh homemade fruit juice may be allowed without added sugars, with a limit of 125 ml per day for 2 to 5 years and 250 ml per day for 5 years. But the main thing is that basic stress should be on the whole fruit, which not only helps in development, but also in the physical growth. Regarding guidelines for school, the ban on sale of HFSS has been a struggle for Uday Pai Foundation, PIL, and some of us also since 2013. And a lot of struggle, a lot of inputs have gone in. The very fact that the food industry people were inducted into this expert committee, you can imagine the Mahabharata which used to occur in all these meetings. With great difficulty, we could lay our hands on 200 meters recommendation around the schools, but finally it has now come back to 50 meters. Then ensuring availability of foods. Whenever you ban something, the first question which school asks you is what should be made available in the schools. Then it comes our role in guiding them and having a national school canteen policy which can guide all the schools around the country to make available healthy snacks and nutritious meals for all these children alike. Now, this is again a very gray zone right now in our country, where the directions were there to all the CBSE schools, but still date, for the last 7 years also, I have to give that certificate or that order to all the CBSE schools anywhere in the country whenever asked for, because the implementation of such law is also a big, huge responsibility. Then providing availability of drinking water. Drinking water, when what's not available in schools or the parents were not sure about the hygienic practices, they used to land up in sending cold drink bottles to the children, along with the children. So ensuring safe drinking water being available in the schools is also our responsibility. Then for food labeling. Ma'am, next slide, please. Guiding for labeling or advertisement. Advertisement, as already pointed out, every 1 hour of TV advert has 25 minutes, has 25 minutes of advertisements, and 60% of these advertisements are related to food. So a child who is watching TV since the age of 6 months, since infancy, is more attracted towards these ads which are loud, which are catchy, which are more colorful, and rather than the main content. And they consider it as a part of the content. So as low as a 1-year-old child can recognize these logos of McDonald's or any other food items, and they can go on and try their pestering powers on their parents and their caretakers to ensure them. So we need to concentrate on them. Advertisements have been, it's a huge area. And imagine the plight of the country or the world where the soft drinks are sponsoring sports events, where the our media personalities who do not consume anything of that sort are advertising for that. So this is the most sad part where we all need to create awareness. So therefore, what the group suggested was to have a differential GST on all the high fat, salt and sugar foods, and also as compared to the healthy food and beverages, and ensure availability of all these healthy food menus even in the markets and the restaurants, and curb the round the clock availability. These days the junks are available 24/7. Even when the parents are sleeping, the children as low as 3 or 4 years can order their junk of their choice and have their meals. And imagine the plight of the child who's exposed to a stranger also at the midnight. Then regarding the marketing strategies, there should be no sale on food items. The ek ke saath ek free. This is the most sad part of the advertising policy, which is hampering everything, because everything which is free is readily acceptable and is never accounted for. So these things have to be curbed. Then the ultimate change will be brought out only by the behavior change, because we are not looking in terms of the short gains like losing weight or just improving appearance before marriage or something like that. Our target as a pediatrician is achieving lifelong behavioral change, so that these lifestyle changes, they become a positive behavior which is acquired during childhood and it persists during adulthood. And we have been through a process of all these, and I was associated with many of these activities, submitting the document to the High Court, submitting to the ministry, and finalizing in the Nielsen's guidelines. Everything was a part of it. And we were expecting the FSSAI to finally finalize on the pack labeling as traffic light labeling regulations, green to go for it, having 80% of the items from green label to be available in the schools. But unfortunately, rather, I went into depression when I saw the order here that it was again restriction of ban sale of junks only 50 meters around the schools, and there was no mention of the traffic light regulations. It was a very sad day which I faced, and the policy, the recommendations have been just diluted. So you can imagine the amount of pains, the amount of energy which goes into these legislations, and formation of these legislations, recommendations, formation of these recommendations, and what happens actually when they are released, and then again when they are implemented. So another sad part is that we are a part of advertising for healthy, so-called health drinks, because now what we are observing that the obesity is increasing not only because of increased intake of unhealthy food, but excessive intake of healthy food is another this thing. We find children consuming Bonvita because Pediasure, you can take any health drink. They are being advertised as health drinks, and they are actually unhealthy. I say they should be placed under sugar sweetened beverages, and all the pediatricians should have the awareness on this aspect, and they should see, they should, if you start reading the labels, you'll get the answers. You see the amount of sugar in Proteinics, you see the amount of sugar in Pediasure, all these health products. I am not blaming anyone, it's our fault. Children start jumping by having 3 or 4 teaspoons in the morning, and they feel that they are growing. The parents are very satisfied that my child is so active, and they are being promoted for even winning races. So this, our focus should be that there should be no food ad in the kids program, at least till 9 p.m. There should be a strict law for misleading ads against both, not only the manufacturer, but also on the media personality who has advertised for it. They should be made responsible. What is the fun of if they are earning 5 crores and they are being imposed a fine of only 10 lakhs for misleading ad, they will happily give away the 10 lakhs. We need to curb our practices, increase the awareness, curb the tendency to manipulating research. The IMS Act has been made, but what is happening? There is no scare of the punishment. Nothing happens actually. We are reporting what is happening, but actually what is happening, you all know about it. Then we have been, for the last 7 years, I was also a participant to this, and still I am a part of the front of pack food labeling at FSSAI. We have been a part of it. I used to think that if we label the food as a traffic light signal, that this food item has high fat and it is marked red, people will stop taking it. But what I observe now, I feel as a part of that group, it is a very difficult thing to do. The front of pack labeling to do is the most difficult part of it. That is why FSSAI left it for has formed a separate committee for that, and we have been working for the last 6.5 months on this. If you label everything as green, people will start taking it more, thinking it is very healthy. And then if you start excessively taking it, because nobody is reading that it is for one serving. Nobody has ever read on the label what is the serving size. The serving size, even in a 200 ml of juice, which is sugar sweetened beverage, is labeled, the label is for 100 ml. And this happens that nobody stops taking the SSB after 100 ml. He has to consume. So my plea is that every labeling which should be
Madam,
done,
I think we are
that we should
time is a bit limited, madam. Excuse me. I think we have to stop. Okay.
So we
We
need
can
to
take
create
another 5 or
awareness
7
so
minutes or so.
the children and the community says that we don't need junk food and we don't need any legislations for this. And with this, I thank you so much.
Thank you, Dr. Rega Harish, for that presentation and all the preamble of all that. I think we should be going for the traditional food, which gives 100 kilocalories, 100 grams. Now, 100 grams is giving 600 kilocalories or even up to 1,200 kilocalories.
2,000.
We should be going from the high energy, low nutrient to the low energy, high nutrient, as Dr. Rega Harish was telling, the traffic signal type of labeling. I think there should be innovative and ongoing behavioral change, self-weighing, self-monitoring, family activities, group exercise, fat taxation. Then Michelle Obama said salad bars to classrooms, compulsory PT periods, even a proactive message on stairs. You are burning 0.5 calories. You are now burning 0.1 kilocalorie. Like that, then we will not take the elevators. I think there is a nutrition-friendly school initiative by WHO. And in this preamble, we must say that Dr. T.U. Sukumaran started child-friendly school initiative program with 5 clauses. I think IAP should add the 6th clause as the nutrition-friendly school initiative and take it to the forefront. So with this, I think we finish, and the chairpersons can ask 1 or 2 pressing audience questions. Otherwise, they can put it in the group also, we can answer.
Thank you, madam, for that wonderful session, and all the panelists I thank. A very important topic, and everyone has done the topics very well. And there are only one or two questions, and I think we can take it that way. One is from Dr. Avinash Benzal, whether the breast milk banks supply milk after discharge from the hospital. Dr. Satish Tiwari can answer this question, I believe.
Yeah, can I?
Yes.
Can I take it up? Yeah.
Yes, madam.
See, donor human milk is basically not going to substitute the breast milk. It is just an add-on till the mother establishes her lactation. So in the human milk banks or the comprehensive center, lactation center, what we do is we encourage the mothers to learn breastfeeding and establish breastfeeding before she is discharged from the hospital. So very few cases where mother is not available will go with the donor milk, rather than, I would say, majority of the mothers would start breastfeeding before they are discharged from the hospital.
Yes, there is another question from Dr.
Hello.
Geeta Patil. That is to Dr. Himabindu. What are the causes of picky eating, and what is the approach in handling picky eating? Whether is there a role for psychologists? Dr. Himabindu, please. Elizabeth, madam, I think she is not there.
Sir, can you repeat the question?
What are the causes of picky eating, and what is the clinical approach to this problem?
Usually, picky eating is one of the reasons I showed. That is the non-responsive feeding behavior in the family. That may be the reason. One. Second, very few children may have some sort of an infantile anorexia or some chronic disease which may have to be addressed. But most of the time, we find that these picky eaters have normal weight. So they and still they may be given more of the so-called healthy food like health drinks, etc. And finally, they end up as overweight and obesity. I think behavioral modifications, counseling, that is the answer.
If yes, Dr. Tiwari.
Can you just repeat Dr. Bansal's question?
Bansal is asking.
Can you repeat Dr. Bansal's question?
Yes, Dr. Tiwari, breast milk bank, whether they supply milk after discharge from the hospital is the question. Whether breast milk banks supply human milk after discharge from the hospital.
Something regarding 4 months. No, that madam has already answered. There was some question related to the feeding at 4 months.
Pardon, let me see.
Hello.
Yes, I will see now. Actually, it was regarding father, an important link and often not involved. Building breastfeeding support group more as nuclear family, maybe a neighbor, health worker, etc. And I think this was what he had given. And
Dr. Bellard madam has already answered that.
Yes.
No problem.
Okay.
I think breast milk should not be sold for money. That is the first thing we must. It is donated by a mother to save a baby, and there are some companies who are trying to market it, and we should be very alert about it.
Yes, madam. I think that is a message we need to give. It is not for sale, and it is definitely not for the sale. Yeah.
Ballard madam, what I feel before we discharge the baby, the proper lactation should be established. So there is no question of giving milk from the milk bank. Okay. Once we establish the lactation.
Can I add something, ma'am?
Yes. Yes.
Yeah, because in Rajasthan model, we have started community milk. So even after discharge from the NICU, 20 days any baby requiring the breast milk, that is provided from the CLMC. So, and we have some districts, we have already started this project. So if there is a need for the breast milk, we are not selling it, but it is given free of cost from the milk bank. And we have a collection of even in 1 crore ml of milk, they are in the milk banks of Rajasthan. So we don't have any problem in providing that, and that's for the community participation.
That is excellent.
Thank you for the information, Doctor.
And
If there are
one more question from Dr. Anish sir. Yeah, can we universal vitamin A prophylaxis, vitamin A program instead of vitamin A prophylaxis program? Like we have got a so much from the universal iodinization program. So now there is no iodine deficiency in. So can we start this type of program like universal vitamin A prophylaxis program rather than vitamin A prophylaxis, which is going on?
Yes, sir. Actually, that will be depending upon the evidence that available. Maybe statewide evidence should be there. For example, where the deficiency is it going to be a problem? For example, if you give iodine for a population where their food is rich in iodine, sometimes the Hashimoto's thyroiditis may be a big problem compared to a goiter. So that kinds of granular evidence should be generated, because in India it is not a big problem to generate that kind of an evidence, and our strategy should be based on evidence.
Yes, sir. Thank
so
you,
we
sir.
can have comprehensive program, but it should be based on evidence, and it should be people friendly, and it should be useful for the people. That's all. So we cannot have a uniform program for the entire country, because the need of the country is different in different aspects, and we have to assess the need first. Then we have to give the program.
Thank you, sir.
I think with that we will close the session, and I once again thank Dr. Elizabeth and the wonderful team of panelists on an important issue with social importance. Thank you all once again for giving me this opportunity to chair this session. Thank you. Good night.
Thank you.
Thank you.
Thank you.
Thank you.
We have come to the end of the academic session. Now, to sum up, I invite Dr. Kristin Indumati, President Nutrition Chapter Kerala, President NNF, past President IAP Trivandrum, and Senior Consultant Pediatrician and Neonatologist SUT Hospitals Trivandrum. Kindly take over, ma'am.
I think, can you hear me? Yeah. Yes. I think for lack of time, I won't go into details, but really what a wonderful start for this evening, for this Iycncon and Hmbcon 2020 with the apt theme of Nourish and Flourish, and with Dr. Ketan, Dr. Bakul Parekh, and Dr. Elizabeth Madam welcoming the faculty and delegates. Truly, we enjoy the academic feast. And speakers have done very, very well. And I think I won't go into the details, mainly because of lack of time. A few words from like Priya has really cracked the bottleneck in complementary feeding. And thanks to her, Dr. Shrinimasan enlightened us on the nutritional aids and the importance of breastfeeding and the supplements which are to be received for the preterm and the SAM children. And Dr. Shrija very clearly spoke on COVID and how a balanced diet is more important than individual supplements which can protect. I think these three speakers are really done, and the panel, I think it's really a great initiative by Madam being the moderator, and all the panelists have done very, very well. I think we are very clear about the messages. I wish we take it into the community, especially about junk foods, and the guidelines which have come is all something new, which we all have to learn and take it up in the community. And as Anish sir has really said, the community approach to nutrition, each state is different, and we should have evidence and effective utilization of the food, which we need to, the available food delivery system should be efficient. And Elizabeth Madam was a wonderful moderator. Madam, thank you, and all the panelists, all the faculty. It was a wonderful session. Thanks.
Thank you, Madam. Now, may I request Dr. Somashekar R, Professor of Pediatrics, Sri Balaji Medical College, and Secretary IYCF for his remarks. So, over to you.
Thank you. It is a wholesome treatise, I must say. For a single-minded, you see, mission, one all must have a devotion. I think all are here to protect and promote and support breastfeeding, right from the Priya's introductory and on complementary bottleneck up to the session moderation by the panelists and by the MOIC and strategy and the bottlenecks, everything. I think we now move forward to a vision that how best we are able to implement and succeed in our goal. That should be our motto. I think flourish and nourish would be an apt and ideal theme for all of us to ponder. And I congratulate the IAP Trivandrum branch and the IAP Kerala taking up this in a very luminary way. Thank you very much for the wonderful session.
Thank you, sir. Now for the closing remarks, I invite President IAP Trivandrum, Dr. Bennett Stylum, who's also a consultant pediatrician at the Coastal Specialty Hospital. Over to you, sir.
Thank you. First of all, I congratulate Elizabeth Madam and Dr. Priya Shrinimasan and Indumani Madam and all the organizers who are arranging this session. And it was an excellent talk by all the first three speakers with the chairing. And the panel discussion also went very well. And our main motto is to prevention of undernutrition and prevention of obesity. To achieve this, we have to start from the breastfeeding and complementary feeding and child-friendly food for children. Anyway, starting with our program with the help of Alive and Thrive India, I congratulate all the organizers and panelists for having a wonderful section. Thank you. Thank you very much.
Thank you, sir. Now we have come to the end of the program of day one. Hope to meet you all tomorrow. Thank you and good night.
Thank you.
Thank you.
Thank you all.
Thank you. Thank you, sir.
Thank you. Bye.